Welcome back, everybody. We are officially on part 57 of our CPC exam series. I'm Harshal, and today we are diving deep into some seriously high-yield digestive and urinary case studies, straight out of the 2026 CPC study guide. But before we crack into it, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's get this explainer rolling.
Okay, so our game plan for today is pretty laser-focused. We're going to break down GI endoscopies and colonoscopies, untangle those confusing hernia repair classifications, decode cystoscopies and urinary interventions, and then wrap up the whole shebang with a quick summary and a sneak peek at Part 58.
Let's kick things off with Section 1 GI endoscopies and colonoscopy rules.
Okay, let's dive into this. Now, you might be wondering how to handle multiple techniques in one session. This is a massive area where the CPC exam literally loves to set traps, especially around scopes and biopsies. Let's look at scenario A. Say a patient comes in for an EGD, right? An upper GI scope. During this one session, the doc does a biopsy of the esophagus, that's code 43239, and a snare removal of a stomach polyp, code 43251. So how do we code this? Well, the baseline rule is that a diagnostic EGD is always bundled into a surgical EGD. But what about the biopsy and the snare?
Here is the golden rule. It all comes down to whether we're dealing with the same lesion or different ones. If the surgeon biopsies and then uses a snare to remove the exact same lesion, you only code the definitive removal. That's it. But if you're tackling different lesions, like in our scenario where one is in the esophagus and the other is in the stomach, you code both. You just got to use modifier 59, or the more specific XS modifier for a separate structure, to unbundle them and show they were totally distinct services.
Now, let's switch gears to colonoscopies and scope depth. Think of this kind of like a road trip. To code a complete colonoscopy, that scope must travel all the way past the splenic flexure to hit the cecum or the terminal ileum. But what if it hits a roadblock? Maybe due to poor bowel prep or a physical obstruction. In that case, it's an incomplete scope. You've got to report this with modifier 53 for a discontinued procedure if they stop for patient safety, or modifier 52 if it's considered a reduced service.
Moving right along to Section 2, hernia repair classifications.
This brings us to a notoriously tricky part of the surgery section. Picture this scenario. A surgeon repairs an incarcerated ventral hernia and places mesh. What exactly drives your code selection here? Guys, it is so easy to fall into unbundling traps or pick the completely wrong code family if you aren't paying close attention to the operative report.
To nail this, you need to identify 4 absolute key factors. Number 1, location. Are we talking inguinal, femoral, ventral, umbilical, or incisional? Number 2, clinical status. Is it reducible, or is it incarcerated and strangulated? Number 3 is patient age, which is super critical for pediatric cases. And finally, the surgical approach. Actually, this one's huge. Mixing up an open versus a laparoscopic approach will completely derail your code selection.
So the crucial point is, how do we handle the mesh? The mesh add-on code 49568 is separately reportable only for open incisional or open ventral hernia repairs. For laparoscopic repairs and inguinal repairs, the work of placing that mesh, it's already bundled right into the primary procedure code. Try to bill it separately, and boom, instant denial.
Let's dive into Section 3, cystourethropy and urinary interventions.
We really need to look at the specific metrics required for scopes in the urinary system. Consider this scenario. You've got a cystourethropy with transurethral resection of a bladder tumor, what we usually call a TURBT. The tumor measures 3.5 centimeters, leading us to code 52235. The million-dollar NCCI edit question is, do we code the diagnostic scope on top of the resection?
Here is the rule you absolutely must commit to memory. A diagnostic cystoscopy, code 52000, basically means the surgeon just looked around. A surgical cystoscopy means they actually took action. And a surgical cystoscopy always includes the diagnostic one. You literally never code the diagnostic scope separately if a surgical intervention happens in that exact same session.
Now, what about that tumor size? For TURBT codes, precise measurement is crucial for medical necessity. Let's rapid-fire these categories. Small is anything under 0.5 centimeters. Medium is 0.5 to 2.0. Large is 2.0 to 5.0, and very large is anything over 5.0 centimeters. So jumping back to our scenario, a 3.5 centimeter tumor falls squarely into that large bucket.
Beyond just tumor size, you really have to watch out for bundling edits with urinary interventions, especially the ureteral stent. And this brilliantly illustrates why checking your NCCI edits is an absolute must. If you're trying to report the add-on code 52332 for a stent placement alongside a lithotripsy or ureteroscopy, stop and check. Stents are very frequently bundled depending on the primary procedure, so always verify before reporting them together.
All right, we made it to Section 4 Summary and Part 58 Teaser.
Get your screenshot buttons ready, folks, because here is your one-page visual cheat sheet. These are your golden rules for today. For GI endoscopies, use modifier 59 for different lesions and 53 or 52 for an incomplete scope. For hernias, remember, mesh is bundled for lap and inguinal repairs, but separate for open ventral. And for cystoscopy, surgical always includes diagnostic, and keep a close eye on those tumor size ranges. Lock these into your brain because they are guaranteed points on your 2026 CPC exam.
Coming up next time in Part 58, we're jumping into genital, maternity, and endocrine system case studies. We're going to master the coding rules for hysterectomies, deliveries, thyroidectomies, and biopsies. But I want to leave you with a quick, provocative thought to chew on before then. How would you code a globally bundled maternity case if the patient unexpectedly switches doctors halfway through her third trimester? Think about how that global package breaks down, and we'll decode it together in the next explainer. See you then.